All right, hi everyone. Thanks for joining for the second session of the Virtual Anesthesia Bootcamp. Today's topic is the induction of anesthesia, and we're going to discuss chapters 8, chapter 11, and chapter 7 of Miller's Basics of Anesthesia. There is a lot to cover, so if there are any questions, I'm not going to be able to cover everything. I'm just going to hit a lot of the high yield points of each of these topics. My name is Robbie Shaw. I am an assistant professor of anesthesiology at the University of Wisconsin in Madison. I primarily practice pediatric anesthesia, and I've been in this position. I direct the medical student clerkship for about 4 years now. All right, so the term induction. What is induction and what does it mean of general anesthetic? So we want to create a reversible state of hypnosis, amnesia, analgesia, and akinesia. So fancy terms that mean a patient is not going to recall what happens, a patient is going to have appropriate pain control, and the patient is not going to move during a surgical stimuli or during whatever procedure we're anesthetizing them for. So we're going to talk about two specific cases today and different forms of how we could induce general anesthesia, and then go into some of the topics from Miller. So case one is a 24-year-old, 70-kilo male. He's otherwise healthy, and he has a 3-day history of right lower quadrant abdominal pain. He's found to have acute appendicitis, and he's scheduled for laparoscopic appendectomy. So he has no notable past anesthetic history, surgical history, and he has no family history of any anesthetic problems. He, as I said, is fairly healthy, takes no medications. He's been appropriately NPO for 24 hours, but he has had 3 episodes of bilious emesis in the past 24 hours. So I think there is a chat function enabled and also Q&A. I think either could be fine. Actually, chat probably be best. Anyone have an idea of how we should induce general anesthesia in this patient that I just described? We'll give it like 10 to 20 seconds just because we do have a lot to cover. So someone said Propofol. That's a good choice. Anyone else? RSI. So that's also a great choice. And we'll do one more. SIBO, ketamine. Okay, all great different options. So first thing we need to decide, how are we going to induce this patient? Are we going to do an IV induction, or are we going to do an inhalational induction? So different methodologies of getting a patient into that general anesthetic state. So in the patient we described, IV is the choice 100% of the time. So the patient has a presumed full stomach. He's been vomiting for the past 24 hours, and he has an intra-abdominal process going on. So we want to induce anesthesia and get a breathing tube in as quick as possible. So choices of medications. So the red and the big lettered medications are the ones we're going to touch on today. So plus or minus a pre-medication with midazolam, so benzodiazepine. Many of us would give some lidocaine prior to induction or as a part of our induction. Any choice of induction agent here. So propofol, etomidate, ketamine, they all have their pros and cons. I think a majority of anesthetics we would do with a propofol induction. Fentanyl, so opioid, which we won't cover today because we'll cover that in later dates for pain control. And then some form of neuromuscular blocker, whether it be succinylcholine versus rocuronium. And we'll talk about both of them today and their mechanisms. And then someone did mention an RSI, so a rapid sequence induction. So that is a different induction compared to a normal induction. So a normal induction, we give our hypnotic medications, wait a bit of time. We then give our neuromuscular blocker, likely then wait a bit of time, and then place a breathing tube in. Comparatively to a rapid sequence induction, we push all of our medications at the same time. So our hypnotic agent, analgesic agent, and the neuromuscular blocker, and intubate pretty immediately after. In this instance, a majority of anesthesiologists would likely do a rapid sequence induction because of that recent emesis and the intra-abdominal process that's occurring. So we talked about an IV induction. So chapter 8 talked about IV anesthetics. So the benefit of an IV anesthetic, there's a rapid onset of induction. We're going to talk later when we talk about inhalational inductions about the different stages of anesthesia, which were described when ether was first utilized. So IVs go from a patient who's awake to a deep general plane of anesthesia very rapidly within seconds. Some downside of those high doses, it's really hard to really gauge how deep someone is. So we give a typical induction dose of propofol. So we give 2 milligrams per kilogram of propofol. In a normal patient, that should put someone in a fairly deep state. And in some patients, it can actually put them into burst depression with an isoelectric EEG. But in some other patients, so say a patient who is a chronic alcohol user, that 2 milligrams of propofol, 2 milligrams per kilogram may not be enough to ensure that you have an amnestic and hypnotized patient. Another downside of the rapid dose of induction, it will impair spontaneous ventilation, which in a lot of our cases is not the most ideal situation. Other things that are typical of IV anesthetics, there's a rapid recovery after a single bolus. So we give a dose of propofol, we expect recovery typically within 8 to 10 minutes if we don't continue or adjunct with any other medications that we have. When we do IV anesthetics as a prolonged infusion, so say we're doing a total intravenous anesthetic, the recovery is much prolonged when compared to inhalational anesthetics, which we'll talk about later. So as a general rule, IV anesthetics are lipophilic, so they are attracted to brain and spinal cord. They will then redistribute when they are getting eliminated from the body to adipose tissue and to skeletal muscle, which then enables that rapid recovery. With the continued infusion, the redistribution phase takes a lot longer because we have accumulation in those tissues that I described. So the different classes of IV anesthetics. So majority of the IV anesthetics act on GABA A and they're agonists of GABA A. So propofol, etomidate, and barbiturates are in that class. Benzodiazepines, which we're not really going to touch on very much today because they're more utilized as a pre-medication to an anesthetic. These also act on GABA, just a different receptor. I remember these by most of them end in PAM, minus midazolam, which is the most common that we utilize. But we have lorazepam, diazepam, and many other outpatient benzodiazepines that that a patient could be taking. We have our NMDA antagonist, which ketamine in IV anesthetics is the only drug. And then we have alpha-2 agonists, which we're not going to talk about today, but dexmedetomidine is in that class. Clonidine is also there as well, just as a straight alpha agonist. But these, again, more pre-medications or medications to help with emergence from an anesthetic, not to actually induce a general anesthetic. So majority of the induction drugs are going to be acting on GABA. So GABA, we remember back from first year of medical school, it's an inhibitory neurotransmitter. So these IV anesthetics are going to activate GABA A, and it sends inhibitory currents across neurons. And as I keep saying here, most IV anesthetics will act, but they act on GABA, but different sites of the GABA A receptor. So now we're just going to go into the different IV anesthetics, the most common ones. We're going to talk about propofol, etomidate, and ketamine specifically, and the different little nuances of each. And this is going to be very clinically relevant for the rotations that you're going to be doing soon. So propofol is a GABA A agonist. It increases flow of inhibitory chloride current in neurons, and it is a non-selective binder of GABA. It comes as a 10 milligram per mil formulation. It is white because it's an emulsion that's in 10% soybean oil, along with an egg protein, which gives it its milky white property. The special instance of this is we need to discard it after 12 hours. So you draw up your medications at the beginning of the day. Propofol, we always write the time that we drew it up to know 12 hours later that we cannot give it, just because there can be a lot of bacterial contamination with how it is formulated. It is metabolized via P450, as a lot of our medications are going to be metabolized. and glucuronidation reactions in the liver, and then inactive metabolites are renally excreted. So propofol is a hypnotic agent. It has no other components at all. So it is not an analgesic agent at all. So when we're running a TIVA, so a total intravenous anesthetic, we want to make sure to get those other properties to get into a plane of general anesthesia. So it being only a hypnotic agent, yes, it will put a patient into what appears to be a sleep-like state, but it might not necessarily be considered a general anesthetic because we don't have those analgesic components. So we typically, when we induce anesthesia, add some form of analgesia on top of the induction dose of propofol that we give. So different effects of propofol. So overall, it's very well tolerated, and a lot of these are dose dependent. So we're going to go different organ systems. So the central nervous system, it creates hypnosis, which is what we want. It decreases cerebral metabolic rate of oxygen, so CMRO2. And I'm going to mention this multiple different times, especially when we talk about volatile anesthetics again. It decreases cerebral blood flow, which therefore then will decrease your intracranial pressure. It maintains your cerebral autoregulation, though. So we are maintaining normal oxygenation of the blood, oxygenation of the brain, even in the setting of the decreased cerebral blood flow and the decreased cerebral metabolic rate of oxygen. When giving at high doses, if you're monitoring an EEG, you can see burst suppression, especially after an induction dose that we give. Cardiovascularly, again, dose-dependent drop in blood pressure. So it's primarily from a drop in your systemic vascular resistance from vasodilatation. You see a decrease in preload and afterload. And this is much more profound in patients with underlying cardiac disease. And in the patient we discussed, the 24-year-old male, he can have very high doses of propofol and likely not see any kind of drop in blood pressure at all. Respiratory-wise, there's a dose-dependent apnea, so giving higher doses will be more likely to make a patient apneic. Overall, whatever dose you give, it's going to decrease your minute ventilation. It's going to blunt the responses to apnea for hypercapnia and also hypoxia. And it can also cause a pretty profound upper airway obstruction from upper airway muscle relaxation, which is why we need to support the airway with positive pressure ventilation or other forms of support, such as oral airways or jaw thrust. So propofol, overall, very well tolerated. It's a great antiemetic agent, which gives it another reason that it is so well utilized. So say a patient has very profound postoperative nausea vomiting, propofol would be a great choice as the primary anesthetic for the patient. It can cause a bit of pain on injection, and this is going to vary per patient, also per size of IV that you have. So if you have a tiny 24-gauge IV in the hand, it likely is going to hurt much, much more than a 16-gauge IV that's in an AC of a patient. So mainstay, put it in a large vein, larger IVs, likely the pain on injection will be less. There's many different ways and there's many thoughts on how to pre-medicate for the propofol pain on induction. I have seen everything I've mentioned here work, and I've also seen everything mentioned here not work as well. Some people prefer to give a little bit of opioid to treat the pain on injection. Some people prefer to give a dose of lidocaine. Some people prefer to do a mini beer block, meaning you exsanguinate the arm, so put the arm up and then fill that arm with a little dose of lidocaine to try to numb the vein before giving propofol. As I said, many different thoughts on how to prevent things. Things that we will not encounter, and when I say not encounter, I mean in a typical, say, hour to 2 hour surgery, we will not encounter something called propofol infusion syndrome. Every case that I've seen of this has been in the ICU. It's typically 20 hours at high dose propofol, not encountered with an induction dose at all. And it's a sequela of symptoms of hyperkalemia, rhabdomyolysis, can go into acute renal failure. And it comes from those high doses of propofol. So not really an intraoperative anesthetic issue. Presumably, if you're in the case for 24 hours, you might see it. So it is something we need to know about, but not for an induction purpose. Propofol is also great because we can use it as a sedative for monitored anesthesia care. So this is the first MAC we're going to talk about today. And it really can be a light sedation, a moderate sedation, or deep sedation based on the doses that you're giving to the patient.
Dr. Shaw, there's a question in the Q&A if you want
Oh,
to
yeah.
grab
Does
that.
the 12-hour propofol timeline apply to continuous infusions? It would, yes. The benefit, though, of continuous infusions, we're typically running a dose of, let's say, 100 mics per kilo per minute. And usually we're able to tell when you're going to be utilizing multiple bolus doses. So we'll fill up a 50 cc syringe, we'll fill up a 100 cc bottle, and typically we would utilize that before the 12-hour time frame. I can see some instances where, say, you started a case at 7 in the morning, you were doing a bronchoscopy and you needed to run a propofol infusion. You then transitioned to a volatile anesthetic. It's 8 p.m. You want to wake the patient up on propofol. The correct answer would be to use a new syringe or propofol in that instance. So yes, it does. Thank you for letting me know about the Q&A. I will monitor that more frequently now. Okay, so someone mentioned ketamine. So ketamine acts on a different receptor than GABA. So ketamine acts on the NMDA receptor and it antagonizes the receptor by non-competitive inhibition of the complex. The term that is always associated with ketamine is it is a dissociative anesthetic. So the patient may look to you that they are awake. You give a dose, so say 1.5 milligram per kilogram dose of ketamine, and they are staring at you blankly, and you are wondering, is this patient awake or not? That is very typical of a ketamine induction that you're giving. And I always tell the residents, the med students that I'm working with, that this is very typical of what you're going to see. You then very likely, depending on the dose that you'll see, will see nystagmus, so their eyes will roll back and forth, side to side. And that is very common with this form of induction. So it provides hypnosis. So even though the patient looks like they're awake, they are hypnotized. It provides analgesia in comparison to propofol because it does antagonize the NMDA receptor. And the amnesia aspect is a little hard to clarify. So if given as the only agent, you sometimes will have patients say that they remember hallucinating, which is one of the side effects of ketamine. So you're really unclear, are they truly amnestic at the time? I always give, when I'm doing an induction of ketamine, in conjunction with the benzodiazepine to ensure that we have the amnesia. So doing it as a dual agent. Ketamine is a great drug because you can give it either orally, IV, intramuscularly. So it has many uses depending on what you need it for. It's metabolized primarily in the liver, again, by the P450 system. It does have an active metabolite that's called norketamine that is renally excreted. So ketamine, in contrast to propofol, will increase your cerebral blood flow and increase your cerebral metabolic rate of oxygen. And this is primarily from cerebral vasodilatation. In theory, it will increase your ICP. Whether or not that is clinically relevant is up for debate. There are many instances where in neurotrauma patients, ketamine actually is the correct choice to induce a patient with, even with that transient rise in ICP that you have. It is pro-epileptic at low doses, but at high doses does prevent seizures. So you can give it into patients with a history of seizures, especially when you're doing high general anesthetic doses. And as I mentioned, will cause hallucinations, which is why I'll always administer it with a benzo when we're doing it at high doses. One of the main benefits of ketamine we don't see as profound of a decrease in our cardiovascular system. So we will see a rev up in our sympathetics. So we'll see an increase in heart rate, an increase in blood pressure, and then an overall increase in our cardiac output. Maybe confusing though, because it says here a direct myocardial depressant. So it is, but our sympathetics are revved up. So we're seeing an increase in our norepinephrine levels. So it is a terrible choice to pick in someone in already decompensated heart failure. So people who have sympathetic overdrive and who've had it for quite some time, ketamine actually can cause direct myocardial depression and cause the patient to go into cardiac arrest. Another really good part of ketamine, it maintains spontaneous ventilation. So you can kind of correlate it that the patient looks awake they are likely still breathing as they had previous. So if we are worried at all about a difficult airway, ketamine is a great choice to induce with, because you will not see that drop in spontaneous ventilation. Don't see as profound a drop in airway laxity from giving ketamine. It does pretty profoundly increase secretions, though. So if this is, say we're doing a fiber optic intubation after a ketamine induction, and I'm worried about secretions from it, I typically will give an anticholinergic agent, such as glycopyrrolate, to limit the effects of these secretions that may occur. Ketamine, good for hypotensive due to catecholamine release, but bad for those without endogenous catecholamine reserve. Correct, yes. So someone who is already using endogenous catecholamine, so someone who is in decompensated heart failure, their heart is not pumping well enough, likely your sympathetics are really revved up in order to maintain end organ perfusion. So ketamine will cause typically a rise in those endogenous catecholamines, but when they're already being utilized, you're not going to see that rise. So you basically will end up with a drug that's worse than propofol in someone who does not have current endogenous stores of those catecholamines. All right, the last IV anesthetic that we're going to go more in depth to is etomidate. So etomidate is also a GABA agonist, very similar to propofol. Again, it is a hypnotic agent, but not an analgesic agent, again, like propofol. The benefit of etomidate, it does have a more stable hemodynamic profile than propofol, which we'll go over in the next slide. The one downside of etomidate, which is why many people will not use it, it does cause some adrenal suppression. It is dose dependent. It can occur with a single dose, so it doesn't need to be repeated doses. So in someone who we are worried about adrenal suppression, we're worried about long-term effects, which can happen even after a single dose, etomidate would not be something we utilize. It is metabolized by the liver and renally and biliary excreted. So effects of etomidate, so we do see that reduction in cerebral metabolic rate of oxygen. We see a decrease in cerebral blood flow and a decrease in ICP. It can activate a seizure threshold. So different than propofol and different than ketamine, we can actually see seizure activity, especially in people with underlying seizure disorder. So in electroconvulsive therapy, which we a lot of the times will provide anesthetic, we want seizures to occur. So etomidate does not readily affect that threshold as much as some of our other agents do. So etomidate is a good choice in these instances. Cardiovascularly, stable, minimal blood pressure change. There's a very small decrease in SVR. It's not as potent of a respiratory depressant as propofol is, so there is a benefit from that regard. An endocrine, so as I mentioned, it can cause adrenal suppression, and it is dose-independent inhibition of 11-beta hydroxylase, so it prevents the conversion of cholesterol to cortisol, so it prevents that endogenous steroid release. And again, there's lots of controversy regarding this. Is it clinically significant? Is it not? We know it happens, but are we really going to see profound changes? It's hard to say. As a pediatric anesthesiologist, I have used etomidate, I think, one time in the past 4 years. So there are other medications to utilize other than etomidate, but it is a medication that is still utilized, especially in the cardiovascular population. So it is a medication that still is used. So things we're not going to talk about today because we have a lot more to discuss. Benzodiazepines, primarily because they're more of a pre-medication. You can induce general anesthetic with very high dose benzodiazepine, but that is very uncommon these days. Barbiturates, so these are more old school medications, but they do still have some clinical relevance. So electroconvulsive therapy, methotrexate is a great choice for that because it doesn't readily affect the seizure threshold. It also, they're great medications to place a patient into burst suppression. So yes, propofol can produce that at very high doses, but barbiturates can more readily do that at more acceptable doses. So pentobarbital, phenobarbital, there are some instances where we do want that isoelectric EEG, and these are medications that can benefit for that. But in terms of an induction, not as very readily utilized. And then dexmedetomidine, I use this all the time. It's an alpha-2 agonist. I use it as a pre-medication, as a post-medication to prevent emergent delirium. But in terms of an induction, getting doses high enough would be clinically almost impossible with dexmedetomidine solely. So we're not going to talk about this today.